Scleroderma is a chronic connective tissue disease. The term scleroderma means hard skin in Greek. When scleroderma only affects the skin, it's considered localized. But if it affects the skin and internal organs, it is considered systemic and referred to as systemic sclerosis. The exact underlying cause of scleroderma is unknown. The pathophysiology of scleroderma is very complex and involves these three processes. Diffuse microangiopathy, which involves extensive capillary loss and obliteration of small and medium-sized arteries. Inflammation and autoimmunity, and visceral and vascular fibrosis in multiple organs. Pathogenesis begins when a genetically susceptible individual suffers a vascular injury, which ultimately results in inflammation, autoimmunity, and changes in vascular structure and function. Endothelial cells and platelets are activated. Reactive oxygen series, ROS, are also generated. This leads to production of the hormone endothelin-1 and recruitment of leukocytes such as T cells, B cells, monocytes, and macrophages. These leukocytes release inflammatory mediators which result in fibroblast activation. Fibroblast activation eventually results in tissue fibrosis, which is the replacement of healthy tissue with dense, stiff, and acellular connective tissue. The B cells recruited earlier also produce autoantibodies which contribute to vascular injury and fibroblast activation. When endothelin-1 is produced, it leads to obliterative vasculopathy, which is the destruction of small and medium-sized arteries, then subsequently to tissue hypoxia. Tissue hypoxia also results in activation of fibroblasts and tissue fibrosis. In the skin, fibrosis causes expansion of the dermis and destruction of the hair follicles, eccrine glands, and other appendages. Collagen fibers then accumulate. The intradermal adipose or fat layer deteriorates and may completely disappear as scleroderma progresses. In the early period of scleroderma, white blood cells such as T lymphocytes, macrophages, and eosinophils infiltrate the alveoli in the lungs. Interstitial fibrosis and vascular damage occur as the disease progresses, which leads to impaired gas exchange and pulmonary hypertension. This complication is known as systemic sclerosis-associated interstitial lung disease. Scleroderma may cause pathologic changes in the GI tract at any level, from the mouth to the rectum. Once normal intestinal tissue is replaced by fibrous connective tissue, peristalsis, which involves the movement of food through the digestive system, becomes diminished. This can lead to gastroesophageal reflux and small bowel obstruction. When scleroderma causes excess collagen to be deposited in the renal arteries, it results in the narrowing of these vessels, leading to decreased blood supply to the kidneys. This complication is known as scleroderma renal crisis. This condition can progress rapidly and lead to renal failure. Scleroderma frequently affects the heart, and fibrosis of the cardiac conduction system is common, particularly at the sinoatrial or SA node. Those arrhythmias and cardiac conduction defects are common with this disease. Other myocardial damage may also be due to fibrosis causing arterial narrowing. Risk factors for scleroderma include being of female gender, particularly during the childbearing years, age 30 to 50 years old, African American, a positive family history, and silica exposure. Individuals with scleroderma can be grouped into two types: limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. Limited cutaneous systemic sclerosis is sometimes termed crest syndrome for calcinosis cutis, Raynaud's phenomenon, esophageal dysfunction, sclerodactyly, and telangiectasia. Raynaud's phenomenon is typically the first clinical manifestation and may precede the other symptoms by years. Diffuse cutaneous systemic scleroderma is linked with extensive skin induration that typically begins in the fingers, then spreads to the limbs and trunk. Individuals in this group usually have early interstitial lung disease and acute renal involvement. Scleroderma signs and symptoms as well as complications vary depending on the body system affected. Raynaud's phenomenon is represented by episodes of reversible vasoconstriction in the fingers and toes and sometimes even the tip of the nose and earlobes. The episode usually starts with the skin turning pale, then eventually turning cyanotic or blue. Hyperemia, which is an excess of blood that forms the affected area, erythematous or red, begins spontaneously or once the affected area is rewarmed. So the three color phases represent the underlying vasoconstriction, ischemia, and perfusion. Skin thickening is the major factor that distinguishes scleroderma from other connective tissue diseases. The affected skin is firm, coarse, and thickened. This tightening and thickening of the skin on the fingers is known as sclerodactyly. It can result in a claw-like hand shape as it causes the fingers to curl inward. The skin of the extremities and trunk may be darkly pigmented as collagen accumulated in the dermis, such as the sweat, icrin, and sebaceous glands are destroyed. This results in hair loss, decreased sweating, and dry skin. Once the facial area is affected, it can become mask-like with taut and shiny skin, loss of wrinkles, and reduced mobility of eyelids, cheeks, and mouth. As the skin undergoes thinning and atrophy, dilated skin capillaries called telangiectasia becomes more apparent. These lesions are typically prominent on the face, hands, lips, and oral mucosa. Breakdown of the atrophic skin areas can result in painful ulcers, which can then possibly lead to infection. Calcium deposits in the skin and soft tissues may manifest in those with limited cutaneous systemic sclerosis. This is known as calcinosis cutis. They range in size from very small to large clustered masses, and they sometimes ulcerate through the overlying skin, producing chalky white drainage, pain, and local inflammation. Scleroderma frequently affects the lungs, which is the leading cause of death for this disease. The two main forms of pulmonary involvement, interstitial lung disease and pulmonary arterial hypertension. The incidence of lung cancer is increased as well. With interstitial lung disease, individuals may remain asymptomatic until it is advanced. Early symptoms include dyspnea, exertion, fatigue, chronic dry cough, and reduced activity tolerance. Pulmonary arterial hypertension may occur on its own or in conjunction. With interstitial lung disease, it usually precedes the development of right-sided heart failure. Its first symptoms is typically dyspnea on exertion, chest pain, exertional nursing cough, or near-fainting events, as well as signs and symptoms of right-sided heart failure manifest as the disease progresses. The GI tract is affected in most individuals with scleroderma. As far as upper GI involvement, most will have heartburns, dysphagia, and regurgitation. Hoarseness, chronic cough, and decreased esophageal and gastric emptying may also occur. For the lower GI tract, impaired intestinal motility can lead to malabsorption, nausea, abdominal distension, and pain. In later stages of scleroderma, sac-like pouches manifest in the colon, which can result in perforations and bleeding. Scleroderma renal crisis is a very serious but uncommon complication as it may lead to renal failure and progressive reduction in renal blood flow due in part to the destruction of small vessels begins a series of pathological events which eventually results in severe hypertension and progresses oliguric renal insufficiency. Cardiac disease is another possible complication of scleroderma. It occurs more frequently in those with diffuse cutaneous systemic sclerosis. It may be primary or secondary to pulmonary arterial hypertension, interstitial lung disease, or renal involvement. The heart's conduction system may be affected by fibrosis, which could lead to tachycardia. Other symptoms of cardiac involvement include shortness of breath, fatigue, abdominal or lower extremity edema, or arrhythmias. In early stages of scleroderma, joint pain and stiffness becomes evident. Joint mobility becomes progressively impaired, especially in the hands. Contraction may then develop. Muscle weakness is another common symptom. Other manifestations of scleroderma include dry mouth, as the salivary glands can also be affected by fibrosis. Hypothyroidism is common and due to fibrosis of the thyroid gland. Facial pain and numbness may occur if the trigeminal nerve is affected. Erectile dysfunction is also common and may be the initial symptoms in men.
Hepatitis has some symptoms we should learn to recognize, like fevers, feeling very tired, and loss of appetite. Your tummy hurts, you feel real sick, you will not eat
What is viral hepatitis and how does it affect us? So, this is a question we must all ask. It's time to unravel the complexities of this health condition that has a profound impact on our lives. Viral hepatitis refers to inflammation of the liver caused by viral infections, including hepatitis A, B, and C. Each type is caused by a different virus, namely hepatitis A virus, or have hepatitis B virus, or the HBV, or hepatitis C virus, or the HCV. So let's explore hepatitis A first. This is primarily contracted through close personal contact with an infected person, sexual contact, or the ingestion of the contaminated food or water. So the symptoms to watch out for are fever, malaise, nausea and vomiting, jaundice, dark urine, fatigue, abdominal pain, and a clay-colored stool. Moving on to the hepatitis B, it is commonly acquired through unprotected sex, sharing needles or childbirth from an infected mother. It shares similar symptoms with hepatitis A, making it hard to distinguish without proper testing. Lastly, the hepatitis C most commonly contracted through injection drug use, blood transfusion, or shared personal items with an infected blood. Again, the symptoms are similar to the other two types, reinforcing the importance of getting tested. So if you suspect exposure now, you might wonder how these viruses affect our bodies. Well, once inside, they target the hepatocytes or the liver's primary cells, so the immune system responds with an inflammatory reaction causing damage to the liver tissue. So if left unchecked, this can lead to fibrosis and cirrhosis, where healthy liver tissue is replaced by scar tissue, or the impairing liver function. Further, in severe cases, hepatitis can lead to liver failure, a serious threat to an individual's health.
So how do we diagnose these conditions? Well, there are specific tests for each type. Hepatitis A is diagnosed through the HAV IgM antibody test, hepatitis B through the HB-Sag, anti-HBC, anti-HB blood test, and HBV DNA test, and hepatitis C through the HCV antibody test, HCV RNA test, and in some instances, a liver biopsy or elastography. Once diagnosed, the management often involves antiviral medications, supportive care, and in some instances, liver transplantation. For hepatitis A, supportive care including rest and hydration is often sufficient. Along with the hepatitis A vaccine for prevention, hepatitis B is treated with antiviral medications such as tenofovir and entecavir. Hepatitis C, on the other hand, is managed with direct-acting antivirals. To recap, viral hepatitis is a liver inflammation caused by hepatitis A, B, or C viruses. It is contracted through various means and can lead to severe liver damage if not managed properly. Diagnosis is through specific tests, and management includes antiviral medication and supportive care. Remember, prevention is always better than cure, so stay informed and stay safe.
Ever wondered how to manage a patient with hepatitis A, B, or C? Let's dive right into the world of nursing management for these conditions. First, we encounter the issue of imbalanced nutrition less than body requirements. This is usually related to compromised absorption and metabolism secondary to the hepatitis, as evidenced by a lack of interest in diet, abdominal pain, and associated weight loss. The management for this includes monitoring calorie intake and recording it in a food diary. You would suggest to the patient to eat the biggest meal at the beginning of the day. Encouraging intake of fluid calories such as fruit juices, hard candy, and carbonated beverages is also beneficial. Coordinating with a dietitian and support team can provide the patient with an adequate diet, including protein and fat as tolerated by the patient. Monitoring of serum glucose as warranted is advised, and be prepared to administer medication as indicated, such as antiemetics. Next, there is the risk for deficient fluid volume. This is related to excessive losses through vomiting and diarrhea secondary to hepatitis. Management for this condition includes ensuring an accurate intake and output monitoring, including the losses via vomiting or diarrhea. Regular monitoring of vital signs, including assessment of skin turgor, capillary refill, and mucous membrane, is critical. Keep a close eye on the patient's laboratory values, particularly hemoglobin, hematocrit, serum sodium, albumin, and clotting times. Be ready to administer antidiarrheal agents and prepared to administer and maintain IV fluid hydration incorporated with glucose, protein hydrolysates, and electrolytes. Lastly, we have fatigue related to episodes of discomfort secondary to hepatitis. This is often evidenced by the observed reports of lacking energy levels and intolerance in doing activities of daily living. Management for this includes ensuring an adequate rest periods, especially during the episodes of toxic states, limit visitors, and provide a calm environment. Recommend frequent position changes as tolerated by the patient and ensuring that the good skin care is rendered. Help the patient utilize stress management techniques such as guided imagery or diversional activities like watching TV, and anticipate to administer medications such as sedatives, anti-anxiety drugs, and others. In summary, nursing management of hepatitis A, B, or C involves ensuring a proper nutrition, managing the fluid volume, and addressing fatigue. It requires diligent monitoring, effective communication, and swift action. Remember, every step taken towards better patient care makes a significant difference in a patient's recovery journey.
Let's discover the medical facts about herpes zoster. In the beginning, we must know how herpes zoster happened. Herpes zoster, also known as shingles, is a viral infection caused by reactivation of the varicella zoster virus, the same virus that causes chickenpox. Chickenpox is a primary herpes zoster virus infection. After the infection clears up, the virus stays dormant in the dorsal root ganglia, where it can later reactivate and spread the nerve pathways to the skin, where it results in the uncomfortable rash known as herpes zoster. Although the cause of reactivation is not fully known, it appears that the greatest risk factors for this process of reactivation is a decline in immunity. The possible risk factors for shingles include the weakened immune system, emotional stress, aging, having had chickenpox, and the use of immunosuppressive drugs like steroids and chemotherapy medicines are risk factors for shingles. Now, we will talk about the signs and symptoms. Early symptoms of shingles may include fever, chills, headache, feeling tired, sensitivity to light, and stomach upset. The other signs and symptoms that appear a few days after the early symptoms include an itching, tingling, or burning feeling in an area of skin, redness on skin in the affected area, rest rash in a small area of skin, fluid-filled blisters that break open then scab over, and lastly is the mild to severe pain in the area of skin affected. So how do the herpes zoster or shingles transmitted? The varicella zoster virus that causes both chickenpox and shingles is airborne. It can spread if someone with shingles or chickenpox coughs or sneezes near you, or shares your drinking glass or eating utensils. You can also get it if you come in contact with a chickenpox or shingles rash, by touching something in contact with contaminated hands, or by inhaling particles from the blisters. If you contract the virus and you have not had chickenpox, you will develop chickenpox. You can only get shingles if you've already had chickenpox and the virus is already inside your body. The incubation period ranges from 7 to 21 days. Therefore, the total course of the disease is 10 days to 5 weeks from onset to full recovery. For the period of communicability, an individual with an outbreak of VZV is infectious for the first 2 to 3 days after the eruption. And here's the disease process about herpes zoster or shingles. Test and diagnosis for herpes zoster. Shingles can be diagnosed by the way the rash is distributed on your body. The blisters of shingles rash usually appears in a band on one side of your body. Shingles also may be diagnosed in a laboratory using scrapings or a swab of the fluid from the blisters. The first one here is the viral culture. We have polymerase chain reaction, the PCR testing. We also have here chunk smear, blood test, and lumbar puncture or the spinal tap. We have here the nursing diagnosis for herpes zoster. First one is acute pain related to inflammation and or local lesions along sensory nerves. Second one is risk for infection related to immunosuppression, immunosuppressive therapy, or the status of the host immune defense. And impaired skin integrity related to open lesions and rashes. Let's proceed to nursing management. The following are the nursing priorities for patient with herpes zoster or shingles. The first thing to do is identify the client's level of pain and pain characteristics. The next one is instruct the client to avoid scratching or touching the lesions. Next one is provide cool compresses and topical treatment for the rashes. Administer pain relievers as prescribed. Provide health teaching about the risk factors, pathophysiology, and medical treatment of herpes zoster. Educate the client about the importance of herpes zoster vaccines. Promote strict hand hygiene among the client, caregivers, and hospital staff. Ensure appropriate use of personal protective equipment when caring for the client. Cover open lesions with gauze bandage as indicated. Apply topical antibiotic treatment or administer oral antiviral therapy as indicated. And lastly is administer corticosteroids as ordered. And now, let us talk about how to treat this illness. Herpes zoster treatment helps you avoid problems and fasten your recovery. The ideal period for treatment is 72 hours after the onset of symptoms. Now, we have here the medication prescribed to treat herpes zoster, including antiviral medication such as aciclovir, valaciclovir, and famciclovir. This reduces pain and speed recovery. We have here anti-inflammatory drugs such as ibuprofen to decrease pain and swelling, antihistamine to treat itching, vitamin B complex to help reduce the risk for post-herpetic neuralgia. Capsaicin or Zostrix helps reduce the risk of a nerve pain called post-herpetic neuralgia, which occurs after the recovery from shingles. To prevent herpes zoster or shingles, the CDC recommends 2 doses of the Shingrix vaccine to prevent herpes zoster and related complication. A 2-dose shoot in upper arm schedule is recommended 2 to 6 months apart for people who are immunocompetent, age 50 and older. The CDC also recommends 2 doses of Shingrix vaccine for those who are 19 age or older, immunocompromised. Second dose given at an interval of 1 to 2 months after first dose. And we also have here Zostavax. Zostavax is an FDA licensed vaccine that helps to reduce the risk of getting herpes zoster in individuals 60 years of age and older, given as single dose by an injection under the skin, preferably in the upper arm. And that's all for herpes zoster. I am Jumila Sumirado Mala, your reporter for today, and thank you so much.
Welcome to the Running Squad Game Show. Today we have invited MSU College of Health Sciences to join us for today's challenge. We brought forth top 3 of their students to play. The challenge is that a diagram will appear on screen and they will be given 1 minute to familiarize everything before they need to recreate it. The one who does not finish their part within a minute or make an error is eliminated. Contestants will be given 3 set cards at random and must complete that part of the diagram. Our diagram today is inflammation in the heart. Considering these are the top 3 students of this college, all these concepts must already be familiar with them. But for you, the audience, let's have a little introduction. Inflammation in the heart happens when pathogens, most commonly staphylococci and streptococci, enter the bloodstream and get to the heart and attach to the walls. The immune system detects these invaders and cause inflammation. Now all they need to understand and differentiate is endocardium is the fine, thin inner layers, myocardium, the muscular layer, and the pericardium, the flexible and fibrous layer. Depending on which layer, distinguished by thickness, texture, and function, different pathogenesis occurs. Endocardium is the layer that gets in contact with blood, so it intentionally activates clotting factors of platelet and blood to create its little nest, aka vegetation in the heart. This can go both ways. It can enlarge and cause blockage, weakening heart contractions, or it can float away to other parts of the body, causing stroke, hemorrhage, or appear on the surface of the skin. Pericardium has solid and fibrous liquid layer which keeps it flexible. If fluid is affected, it can edemize and decrease stretchability. If fibrous layer is affected, heart becomes rigid and is constricted. So it seems our contestants have finished the game. Let's check if everything is on par. Myocardium. If affected, pathogens kill muscle tissues and reduce contractility. All of these infections, if left untreated, causes poor cardiac output, and we all know how important this is. If cardiac output stays low, heart may overcompensate and end in heart failure. It looks like the game has ended in a tie. These 3 players are competitive, ready, and competent. I guess with no elimination today, there are more games to come. In the meantime, let us learn more on the inflammations in the heart.
Hello everyone, today I'm going to discuss the top 3 nursing diagnosis and management of inflammatory heart diseases. First nursing diagnosis is decreased cardiac output. Assess heart rate, rhythm, and pulses. Decreased peripheral pulses are also an indication of decreased cardiac output. Pulses may be irregular or strong beats alternating with weak beats. Second is monitor blood pressure. Hypotension can occur in advanced cardiac failure when the body is unable to compensate for the loss of cardiac function. Third is assess and monitor urine output. With decreased cardiac output, the kidneys will respond by retaining sodium and water, decreasing urine output as fluid shifts onto the tissues. Next is to assess the diagnostic studies. A chest X-ray may show an enlarged heart and pulmonary congestion. ECG can show ST segment depression and T-wave fluttering due to myocardial oxygen demand. Next is to encourage the patient to rest. Rest is essential to improve the efficiency of cardiac contractility and decrease myocardial workload by decreasing oxygen consumption. Next is provide supplemental oxygen. Supplemental oxygen increases oxygen availability for myocardial uptake to prevent hypoxia. Second is to administer medication as indicated. Medications such as antidysrhythmic, vasopressors, and diuretics can help control the progression of reduced cardiac output. And last is to prepare for pacemaker insertion. A pacemaker may be required to keep the heart beating in a regular rhythm. The nurse can instruct the patient on precautions following the procedures. Second nursing diagnosis is impaired gas exchange. First is to determine respiratory status. Decreased oxygenation or hypoxia and quick shallow breath are effects of ineffective gas exchange. It can be accompanied by the following: increased respiratory rate, use of accessory muscles, nasal flaring, abdominal breathing, and anxiety. Second is to auscultate lung sounds. Inadequate gas exchange is linked to diminished breath sounds due to lung hypoinflation. Cardiac heart failure or stiff and stretched heart tissue can cause fluid to build in the lungs, leading to crackles on auscultation. Third is to observe for any change in mentation. Changes in mentation and behavior are early signs of inadequate gas exchange. Cognitive alteration and restlessness can result from poor oxygenation to the brain. Fourth is track the vital signs. Monitor the heart rate, blood pressure, oxygen saturation, and cardiac rhythm. Hypoxemia can result in fluctuations in blood pressure, heart rate, decreasing oxygen saturation, and fetal dysrhythmias. Second is administer oxygen as ordered. Increased oxygen delivery to the cardiac muscle helps the heart contract effectively. This aids in the gas exchange process. Ask the patient to demonstrate pursed-lip breathing. Pursed-lip breathing helps the patient slow the respirations and release trapped air and carbon dioxide. Teach the patient when to seek medical help. Encourage the patient to seek emergency medical assistance if they experience signs of heart failure and complications of poor gas exchange. Third nursing diagnosis is activity intolerance. First is to assess the patient's response to activities. Parameters like tachycardia, dyspnea, chest pain, excessive fatigue, diaphoresis, weakness, and syncope can determine the patient's physiologic response to the stress of activity and evaluate ongoing process or deconditioning. Second is to assess factors that affect the patient's desired tolerated activity level. Consider the activity level of patients, especially children and younger adults, who enjoy playing and participating in sports. Third, assist in self-care while promoting independence when tolerated. Providing care to the patient ensures that the patient's needs are met while reducing the compromised cardiac workload. Encouraging participation in self-care activities, if tolerated, allows the patient to maintain a sense of control and independence. Next is to schedule interventions with rest periods in between. Scheduling interventions and procedures with rest periods ensure that the patient's needs are met without increasing oxygen demand and cardiac workload. Second is to monitor for an increasing incidence of activity intolerance. It may indicate increasing cardiac decompensation. And last is to encourage the patient to adhere a graded cardiac rehabilitation program. It can help strengthen cardiac function without overexertion.